everybody, and good afternoon. Just while we're waiting for people to join in the next few minutes, I'll just do a brief introduction. My name is Nikita Burke and I am the Programme Manager with Evidence Synthesis Ireland, and we're delighted to welcome you all to our webinar series. Thank you all for taking the time out of your day to join us here today. I know it's not easy with many of us very busy or working from home and having other commitments. But we really hope to foster a sense of community in the evidence synthesis field here in Ireland and internationally as well. And we would like to continue to build capacity virtually any way we can during this difficult time. And now we all know how important evidence synthesis is for decision making, particularly now. So with that, we're delighted to have Shelley O'Neill from HIQA here today. Evidence Synthesis Ireland includes Cochrane Ireland and is an all-Ireland initiative funded by the Health Research Board and the HSE R&D division of the Public Health Agency in Northern Ireland. And our key aims are to build evidence synthesis knowledge, awareness and capacity on the island of Ireland, and this webinar series is one of those key activities. So if you are interested in more, you can sign up to our newsletter or follow us on Twitter, where we will announce these. We will have a feedback form sent around at the end. And if you have particular topics that you'd be interested in hearing from, please let us know, because we will use this in curating our series. We will have time as well at the end for some questions and some discussion as well. So if you'd like to put in the questions in the Q&A box then, and then I'll moderate at the end. So Shelley is online. I'll just briefly introduce her. Shelley O'Neill leads the HRB-CICER team based in the Health Technology Assessment Directorate at the Health Information and Quality Authority in Ireland, known as HIQA. CICER independently reviews evidence and provides scientific support for guideline development groups in Ireland. Shelley joined HIQA in September 2010 and previously worked in the NHS and also as a research associate in medical statistics at the University of Cambridge. She holds a Bachelor of Science in Mathematics and Statistics, a Master's in Statistics and a Master's in Health Economics and Health Policy. So today she's going to give us an overview on how evidence from systematic reviews is used to inform national clinical guidelines and health technology assessments in Ireland. This is very topical, as Shelley and the team at HIQA are working very closely with the Irish Government, the Department of Health and the HSE and the National Public Health Emergency Team to provide evidence during the COVID pandemic. So I really want to thank Shelley for taking time out today to present to us. So I'll hand over to you, Shelley.
Great, thanks very much. I'm delighted to be here today. I'll just pull up the share screen there. I think we're all fairly familiar with how Zoom works. As Nikita was saying there, I'm going to talk today about how we use systematic reviews to inform healthcare decisions in Ireland. So as she was saying, I work within the Health Information and Quality Authority, and we provide evidence to inform decision making across a number of areas. Today I'll be mainly focusing on clinical guidelines, health technology assessment, and the work we currently do for the COVID-19 response. However, HIQA, the evidence team within HIQA is a large multidisciplinary team. We provide systematic reviews and evidence synthesis for health technology assessments, clinical guidelines, currently doing this for COVID-19, and I'll go through those today in the webinar. We also conduct systematic reviews as part of our evidence to policy function. And in the future, we will be beginning work with the screening committee, and that will also include a number of systematic reviews there. So it is a large part of our undertaking. We have a large multidisciplinary team that support this work. If I start off with clinical guideline development, because that's where I usually in the day job spend most of my time these days. So clinical guidelines are systematically developed statements based on a thorough evaluation of the evidence to assist practitioner and patient decisions about appropriate healthcare for specific clinical circumstances across the entire clinical spectrum. So you can see here very clearly that clinical guidelines evidence is quite clearly in that definition. Within Ireland, clinical guidelines are endorsed by the Minister, and these are entitled NCEC clinical guidelines, National Clinical Guidelines. So there's a particular process that a guideline has to go through to get that national clinical guideline excuse me, stamp really and endorsement from the Minister. So just to explain briefly how this works. So the National Clinical Effectiveness Committee is was established by the Minister of Health in September 2010. Their role is to prioritise and quality assure both national clinical guidelines and national clinical audits. To date, we have 23 published clinical guidelines, and there are currently 15 in development. Now, some of these in development are updates to the current guidelines that already exist, and some of these are new. So national clinical guidelines get support. As you can see here, they clearly need an awful lot of evidence synthesis, and systematic reviews form part of that. So HRB-CICER, which is Collaboration in Ireland for Clinical Effectiveness Reviews, this is a group that I lead, which is funded through the HRB over a 5-year term from 2017 to 2022. So we're about halfway through at the moment. We include 5 staff, which is across HIQA and our colleagues in the RCSI, the Royal College of Surgeons. And we provide evidence synthesis to support national clinical guidelines. Now, we provide a range of evidence synthesis, so systematic reviews, budget impact analysis, and other things. However, today I'm just focusing on the systematic reviews. It's important to note that we provide systematic reviews both on clinical effectiveness. We also conduct qualitative systematic reviews of cost effectiveness, and we also do systematic reviews of actual guidelines themselves. So we provide systematic reviews on a range of different topics as required. To date, we've supported, that's 5 clinical guidelines now to completion. So type 1 diabetes, maternity early score, nutrition screening and stratification of risk in pregnancy. So you can see there the topics are very wide ranging. The ongoing work is around national early warning score, sepsis, healthcare acquired infections, chronic obstructive pulmonary disease, care of the dying adult, and intraoperative vascular hemorrhage and smoking cessation. So you can see there it's a wide range of topics, and the systematic reviews that support those in the development of guidelines will require that multidisciplinary aspect that we have within our team. So how do national clinical guidelines get developed, and how do systematic reviews fit into that process? So I think the first thing to think about is what they actually need to do. What happens to get a guideline through that process from the start right through the finish? So there are 9 key steps that a guideline development group need to do to get that guideline sorted. First step is set up that guideline development group. So this includes a wide range of stakeholders, which will include various clinicians and patient representatives. Anyone really who has a stake in that guideline topic should be represented on that guideline development group. This group then come together and formulate the guideline questions. So really getting an idea around the scope, what their guideline is going to cover. Once they've decided upon that, then they typically go and review existing guidelines to see if we can leverage off experience internationally. Are there guidelines we can adapt for the Irish circumstances we could adopt or potentially contextualize, so we don't have to restart at the beginning all the time. The next step is to conduct literature reviews to ensure that the guidelines are based on evidence, and these can be new literature reviews or updates. They also then need to develop recommendations. So once you have the evidence to hand, the guideline development group need to develop recommendations to deliver these. They also need to think about the implementation plan. So how are these guidelines going to be actually implemented within the Irish system? And it is up to the guideline development group to clearly think and lay out an implementation plan. They also need to consider the budget impact analysis of the guideline recommendations. So this is about not just about the cost, but also about the resources that will be required to deliver the guideline. They also need to consider monitoring and audit of the guideline. And finally, their guideline, once it is in draft format, goes out to an external review. So not only do we have stakeholders involved in the actual development of the guideline, it also goes out before it is finalized to wider national stakeholders, and it also goes out to international experts. So those are typically topic-based experts internationally who review the guideline to ensure that it, and feedback on that process. But we're here today to talk about how do systematic reviews in particular feed into this process. So what is the relationship between the systematic review and the guideline development? So there are 4 key steps where a systematic review fits in. I mean, I think it's pretty obvious. You'd expect it to fit in there, number 4, with the literature reviews. But it also, the process of developing a systematic review is really important at the scoping stage to formulate those questions properly. In reviewing existing guidelines, we will undertake systematic reviews of guidelines, obviously the literature review itself, but then the developing of the recommendations. How do you take that evidence that's been pulled together and turn that into recommendations? So I'm going to talk about these 4 steps and what we do and how it interacts with that guideline development group. So here is a nice picture. It comes from the grade handbook. And I really like this one because you can see there very clearly, you know, those sort of little figures around that table that are meant to represent the guideline development group, how they fit into the process. And this is really clearly, to me, shows how systematic reviews feed in. So you can see there the guideline development group and those arrows towards the PICOs. That's where they're scoping, where they get their questions. Those questions are then turned into a particular type of question, and we use what's called a PICO framework, where it's really very clearly laid out the various elements within that clinical question. You select your outcomes, you rate which outcomes are important, which aren't. You go across the studies, so that little diagram there. So that's pulling together that evidence. And then that picture there where it shows that little summary table, that's summarizing your evidence, and then that's fed back to the guideline group. So what happens on that blue box is essentially where we input in, where we help them to formulate the question, where we go across the studies, where we summarize the evidence, and then we bring it back to them. And then they include that evidence and think about how they develop the recommendations. So I'll go through some of the steps involved here, but it's just to give you that sense of how the guideline development group generate the systematic review through their questions, and how that the answers to those questions come back and are fed in and lead to recommendations. So scoping, how do we scope the questions? So the guideline development group will be thinking about aspects or parts of care where they want to improve or standardize. So that's typically the aim of a guideline, is to standardize care or to improve care. So I'll just give you an example here of a question that came from the sepsis guideline development group. They were considering including rehabilitation within their guidelines. So they specifically were thinking about a recommendation on outpatient clinics for sepsis patients. So this is patients who have had sepsis, who've been discharged from hospital, but how should they be managed afterwards? Are there particular evidence out there about how best to manage these patients? So they believe there might be something out there that could prevent long-term complications. So we sat down with this guideline development group and we tried to formulate this recommendation that they had in mind into a research question, something that we could go to the literature and investigate. So we turned that consideration that they came to us with into how effective are dedicated sepsis outpatient clinics or post-intensive care unit clinics in identifying, managing, improving long-term sepsis-related complications. So with the guideline group, we would have agreed what constitutes the population. Who are they interested in? And so in this case, it's adults, not pregnant, who have had sepsis or septic shock and survived discharge from acute healthcare settings. So it's afterwards. What happens to the population afterwards? For adults, in Ireland, it's usually patients aged 16 or older. Within the hospital system, they're classified as adults. But if we're going to the literature, adult will typically refer to 18 years or older. So what intervention were they particularly interested in? So sepsis-specific outpatient clinics or perhaps post-intensive care unit clinics. So really clear on what it is, the intervention they're considering here. The comparison was decided to be left broad, could be usual care, whatever that was in the particular studies, and the outcomes of interested. So the primary outcome they were interested in seemed to be around improving quality of life. Secondary outcomes around outcomes identified post-hoc. So post-hoc, which means essentially we could leave that broad, see what came up. So this is how we turned what they were thinking about into something concrete that we could go to the literature for. So that's the first interaction we'll have with the guideline development group, is around scoping and formulating questions and things they're considering into something that we can go and investigate in the literature. The next step is for them to review existing guidelines. So if they have clear questions, then it's important to investigate if there is already a good quality guideline out there that addresses this issue. So this is where we support guideline development groups in looking at what else has been done internationally. What other guidelines are out there? Are there things we can adapt for the Irish system, perhaps adopt or contextualize? So A systematic review of clinical guidelines then is conducted. Now, the WHO says that this should be broad without limitation, as guidelines can be difficult to find through electronic citation databases. I mean, for example, the guidelines we have here in Ireland, the NCEC guidelines, they're on the NCEC website. They wouldn't appear in a PubMed search. So when we search for clinical guidelines, we need to search the places where they are housed, which is slightly different to normal clinical literature. Then we appraise the guidelines. We apply quality appraisal. I mean, quality appraisal is something we would do always with any type of study, but it's important to note here that regardless of the evidence you're looking at, you do need a formal quality appraisal of it. So in this case, it's the Agree-To tool, which is the standard tool that's used for assessing quality of guidelines. I mean, it's important to note as well that within HIQA, we do follow best practice guidelines, and there are many guidelines on how to do systematic reviews in all of the various contexts that they arise. The other thing that's involved by a guideline is how current is it? These are, the evidence around a guideline and the recommendations can change. So it's very important to determine the currency of it. Then the content analysis, this is where you examine the guideline recommendations and see how applicable they are to the Irish situation. So I think of those three aspects there, the appraising the quality, determining its currency. Those are aspects that HIQA, as HRB-CICER, we're methodological experts, we're quite well placed to do that. However, something like content analysis, where you examine the guideline recommendations and see how appropriate they are to the Irish healthcare system, including all of these, the wider stakeholders, that's something that has to be done in conjunction with the guideline development group. So that's again another situation where we'll go back to them with the guidelines we've identified. This is how we appraise quality, this is the currency, but these are the recommendations themselves, and the guideline development group get involved with their various expertise and their various, with that wider stakeholder input. Once this has been decided upon, the guideline development group then can either adopt, and this is where you take a guideline directly and you take the recommendations as is and say they are directly applicable to Ireland. You can adapt it. This is where you amend it to match the Irish system, where things need to be, adjusted to fit our context. Or you can contextualize, and this is a process that NICE has developed, so it's only really applicable to NICE guidelines. And we've done this with the type 1 diabetes guideline, where we contextualized a NICE guideline into the Irish situation. And the final option there is de novo. So that is where you essentially, there isn't anything in the international literature you can use, and you do a de novo search and you develop your recommendations from beginning. It's also important to note that a guideline will have a number of different recommendations, and there can be a mix of methodology used. So some recommendations might be de novo, some may be adapted from other guidelines. So again, there is just showing how we link in with the guideline development group to help them decide on the best approach for their guideline. So the next step then is around the actual literature review itself. So once we've decided upon their approach, once they're happy with their approach, then they need to decide whether literature reviews are required. And these can be new literature reviews, if it's a new question that's not been identified before in another guideline or a high quality systematic review, or it could be an update. So an update would be, for example, if a guideline that they wanted to adapt was 4 or 5 years old, we would update the evidence. Or for example, if it was a question they were interested in, a high quality, for example, a Corcoran review existed, we might update that review. So systematics are conducted, and as mentioned earlier, these could be effectiveness or qualitative, in whatever particular type of systematic review is required. But then what happens? So it's important to remember who guideline development groups are. So they are multidisciplinary groups consisting of a wide range of stakeholders, and some of these individuals have little research experience. But the reason why they're part of that guideline development group is that their voice counts, and they need to have all of the information to hand to input into the decision. So when we produce a systematic review, it's often long and complex, might have multiple outcomes with varying importance and relevance, might have a lot of complex statistical discussions in there, technical terms and abbreviations, might have varying risk of bias among the included studies, all of this stuff that we have to, as systematic reviewers, consider. However, for the guideline development group to make an informed decision and for that multidisciplinary stakeholder involvement that we want, everybody needs to have a common understanding of the evidence. So what we do, and it's best practice out there, is we use the grade process to summarize that evidence in a way that is understandable to everybody around that table. So we use the grade evidence. So this is where judgments are made about the quality of the evidence for each main outcomes across all the available studies. So the grade gives you a very quick overview about how confident we are in the estimate is as close to the true effect. I mean, it's quite understandable because the quality ratings rate from high, moderate, low to very low. And working with guideline development groups, they understand very low means not great. They understand that high means, we are quite confident in the literature. So it's a way of trying to summarize that literature for them so it makes it quick for them to understand and it's clear. So quality is around, we use that grade system to provide that quality, where high is we're very confident the true effect lies close to that of the estimate of that effect. Now that can sound a bit wordy, but in practice, it's about a particular question. So we will be telling you we're very confident that the evidence we found is high quality or not. It's also important to note here that this is done for each outcome. So if you think back to that sepsis example where I was talking about the outcomes might be the quality of life, or it might be long-term complications, we would give a quality rating for each one of those outcomes. So they can see then when they're making the recommendations, which are the important aspects that they wish to consider. So putting all of this information together, we use the summary of findings table. Again, this is standard grade practice, and it includes that PICO, so that clear question. It includes the outcomes. It includes a brief overview of the results, so the participants, the relative effects, the absolute effects. Also includes an element of the quality of the evidence, which I just described there using that grade approach, and the comments, some comments and footnotes. But this is all about trying to make what is a long and complex, sometimes complex process of a systematic review understandable for those who need to make the decision. So I've given an example here of a narrative summary of findings table, because this is something that I think happens within the guideline development process that mightn't happen as much in the academic literature, because we do need to pull things together. They are quite, might not be as straightforward sometimes. So in this case, we're looking at early warning score interventions for detecting acute physiological deterioration. So that's clearly there at the very top, what the question was. Then the PICO elements, the patient population, the setting, the intervention, and the comparison are all listed clearly there. So this guideline development group would have been involved with us in developing those questions and developing and agreeing that clear PICOs. So when we develop the questions, we will also develop a clear protocol, which will be shared with the guideline development group so they know exactly how we're approaching the question and they can feed into that process. And then from the process side of it, would also submit that protocol to Prospero, so it's clearly transparent what the processes are. So all of that information at the top should be familiar to them already when this comes back. They know this is what they agreed, this is what we found. So as I mentioned there, for each outcome, there is a summary of the literature for that outcome. So the first one there, mortality, we can see that certainty of the evidence on the very right says very low. The number of participants in studies, it's clearly there. We have 12 studies, which was a mix of 3 RCTs, 5 observational studies, 3 pre and post intervention studies. So you can see there that there's a mix, and it's very clear to them that there's a mix of studies involved. And then in the impact section, there is a short narrative overview, which says the definition of mortality between the 12 studies varied, as they did not, interventions applied were different. As a result, the findings varied. So 5 found an improvement in mortality or a reduction in mortality rates, and 7 found no significant effect. So that's a very clear, we hope understandable statement for that guideline development group, which includes a number of individuals with varying levels of expertise. So we present this back to the guideline development group so they can understand what the evidence is saying. But then what? So then they have to take that evidence and develop recommendations. But is the evidence alone enough to develop a recommendation? I mean, the simple answer is no. The evidence alone is not enough. Other factors should and are considered when you develop a recommendation. So it's important to remember that evidence is only part of the process in developing recommendations and guidelines. So within the Irish system, it's recommended that the evidence decision-making framework is used to help guideline development groups formulate those recommendations in a structured and transparent way. So this framework enhances the transparency of the guideline so they can consider each criterion and document how they're making the judgments across each criterion to inform the recommendation. So to give you an example of what that means, so there is a list of the criteria, and that's kind of a description of there as a question. So the one which relates to the systematic reviewing is there around that quality of the evidence. Is there high or moderate quality evidence? So essentially we'll have presented that back to them. But that's not enough, because they need to consider, you know, what are the values and preferences of the population? Are you confident about the particular values or preferences? Are they similar to your target population? Is the evidence relevant there? They need to consider the costs or the resource use. They will do this separately through the budget impact analysis, and that can feed in here as well. So are the resources available? Is the cost worth the expected benefit from this intervention? The feasibility, can this recommendation be implemented? As I mentioned earlier, guideline development groups have to actually develop implementation plans. So is it actually feasible to implement this? So all of these strands need to be considered, and the evidence is just one. So when they consider all of these evidence together within this evidence decision-making criteria, they then, they get to their recommendation. And the recommendations are given a strength. GRADE has two categories, which is a strong recommendation or a weak recommendation. And these categories reflect the extent to which the guideline panel is confident that the desirable effects of an intervention outweigh the undesirable effects, or vice versa, across the range of patients for whom the recommendation is intended. So this is where, and quite often you'll see in a guideline development group they'll have a strong recommendation, and then in brackets next to it, they might say weak evidence. So there are situations where, although the evidence might be weak, you want to make a strong recommendation about this. One good example we were involved with recently is they wanted to introduce education system into part of the early warning score, and the evidence around the education was weak. It wasn't strong, high quality evidence around the intervention. It all appeared to work. It did appear to improve nurses' skills in implementing the early warning score system, but the quality of that literature was weak. However, the guideline development group came down saying it should be a strong recommendation that we have education. And one of these reasons was, I remember that the patient representative at that time said, we expect as patients that our nurses are highly trained. So it's that preference that the society we want this education. The evidence is saying that it's weak evidence to say it improves the outcomes. However, there was strong feeling among the guideline development group for those wider evidence and the values and preferences of the guideline group that should be strong. So quite often it's a very clear link between what's strong recommendation and what the evidence behind that is. Okay. So here again, back to that diagram. You can see here that it sort of talks through very briefly about how that guideline development group formulate the questions, how that comes back to them as a summary of evidence from the systematic review, and how they take that evidence and then they come to a consideration looking at the wider aspects about those recommendations and what they should be. Okay, so there's those four aspects again, how it fits into the guideline development process. So I'm just going to move on to health technology assessment. So again, I'm going to have a look at how systematic reviews fit into a health technology assessment. A lot of it is an overlap. So the process of scoping the question, the process of collating it and producing a summary of findings, we do it the exact same way across all of our products in HIQA. We will produce systematic reviews to the same standard and following the same best practice processes. But what's different here is in health technology assessment is the framework is slightly different. So that's what I'm going to focus on a bit here and show you how systematic reviews are used within this framework. But again, a lot of the same principles apply. So a health technology assessment, it's a multidisciplinary process that summarizes information about medical, social, economic, ethical issues related to the use of a health technology in a systematic, transparent, unbiased and robust manner. Its aim is to inform the formulation of safe, effective health policies that are patient-focused and seek to achieve best value. So I think it's clear here as well that there is information here that's systematic and it's around the medical issues. So that kind of clearly points again to the systematic reviews, the transparent and robustness. So systematic reviews are vital in a health technology assessment. So the Health Information and Quality Authority, HIQA, we were established under the Health Act in 2007, and we directly report to the Minister for Health and Children. We're an independent body established to drive continuous improvement in Ireland's health and social care services. Two of the functions that relate directly to health technology assessment in the Act are to evaluate the clinical and cost effectiveness of health technologies, including drugs, and provide advice arising out of the evaluation to the Minister and the Executive. To review and make recommendations as the authority thinks fit in respect of the services to ensure the best outcomes for the resources available. So you can see here very clearly highlights in our function that to evaluate the clinical and cost effectiveness. So the clinical effectiveness and the cost effectiveness. So it really is bread and butter of what Health Information and Quality Authority does as part of health technology assessments. One thing I think that might be a little bit confusing, and certainly confused me initially, was health technology. I mean, it seems like it must be very techie based, but it's not. Health technology is any intervention that is used to promote health, diagnose or treat disease, or is used in rehabilitation of long-term care. So really, health technology can be anything. It could be a drug, a diagnostic, medical device, surgical procedure, public health program, or the organizational support systems that underpin these. Health technology assessment is a decision support tool. So in clinical guidelines, there were recommendations made. In a HTA, it's advice. So in a HTA, we provide advice to the minister or the health service executive, whoever requested the HTA. And we're pulling together a multidisciplinary process, and we're pulling together the safety, clinical and cost effectiveness, looking at the budget impacts, the organizational impact, social and ethical issues. So we're trying to pull all these aspects together to provide advice to those who are making the decisions. So again, you can see there's an awful lot of overlap with a lot of the domains here linking into the various aspects the clinical guideline had to consider. So in the framework of a HTA, we have 9 domains that we consider. Just to run through them, the first ones are the health problem and the current use of the technology. So that usually is around what's the population, the epidemiology, and how are things currently, what is the current situation. The second domain is around the description and technical characteristics of a particular technology that we're investigating. The third one is around the safety. Fourth is clinical effectiveness. Then we move on. Those 4 are called a relative effectiveness assessment. And these 4 aspects are quite often considered alone. And within Europe, there is a group called UNATA, the European Health Technology Assessment. And we try to work together. So those first 4 elements we quite often do in tandem with other European agencies so that we can benefit from each other. Then the next item is around the cost and economic evaluation. Number 6 is ethical analysis, 7 organizational aspects, 8 is social aspects, and 9 is the legal aspects. So if we focus again on where do systematic reviews come in. As with clinical guidelines, we will do different sorts of systematic reviews as is required. So I've highlighted in green there where we absolutely nearly always do systematic review, and that's around the clinical effectiveness. Those ones highlighted in yellow for the safety and the costs and economic evaluation. Quite often we will do a systematic review, but sometimes that will depend on the question that's been asked. So we look first at the first 4 steps, which are the rapid RIA or relative effectiveness assessment. We look at the health problem, current use of technology. We describe very clearly what's there. We look at the safety characteristics of the technology, and then we look at the clinical effectiveness. So focusing on the clinical effectiveness, this will normally include one or more systematic reviews. And again, the safety may include a systematic review if warranted. So we also use the grade process in the same way as we do with clinical guidelines. We need to provide this information to our stakeholders. So something I should have described a little bit earlier there is health technology assessment, in the same way as a clinical guideline, has a clinical guideline development group of all the key stakeholders. In HIQA, when we begin a HTA, we will identify key stakeholders and ask them to be involved. Again, this will include clinical experts, it will include patient representatives, all of those key stakeholders who are involved and relevant for that particular technology. We will then, in the same way as a guideline development group, work with those, as we call them, our expert advisory group, which is essentially that group of stakeholders who will work with them to scope the question and get their input along the way. However, unlike a clinical guideline development group where they make the recommendations, for health technology assessment, HIQA provide advice. So we will formulate the advice, pulling in the opinions and the expertise of that stakeholder group of expert advisory. Okay, sorry. So to go back to where we are here, again, when we're doing systematic reviews, we will go through that PREGO framework. We will talk that through with the stakeholders. We will then create grade tables, which is now increasingly used in HTA as this is best practice, and it's required also by the NETIS, so that European group. But then after the relevant effectiveness assessment is done, those first 4 parts, we will usually stop and consider what the evidence is suggesting. So occasionally, but not very often, the evidence would suggest perhaps that the clinical effectiveness is not strong enough or not clear enough, or the health problem or the description of the characters. There'll be something there that will say, actually, it's probably not worth going on to the next stage. The evidence is not strong enough. The evidence is not robust enough just yet. So all of those 4 aspects would be considered. What is the evidence suggesting, and do we need to do a full health technology assessment? For the majority of cases, we do scoping exercises before we begin so that we rarely start things that go beyond the first 4 steps. But it is something we do within the process. We do stop and think about what the evidence is telling us at this point. Then the next step in the full health technology assessment is around doing that economic evaluation. Now, the first step here is quite often a review of international cost effectiveness literature. Sometimes this is a systematic review, and sometimes it's just a review. And again, after we've done this review, we will stop and consider what that is telling us. So is there evidence out there that's saying it is cost effective or it isn't cost effective? And is that applicable to the Irish situation? So again, we will stop and consider what that evidence is telling us before we move on to the next steps. So for a full economic evaluation, there really are 4 questions that are considered. It's, can it work? So that's the efficacy. Does it work? Is the effectiveness? So that's more about the real life situation. So is it worth doing? Is efficiency? Is it cost effectiveness? And how much will it cost? So that's around the affordability or the budget impact analysis. So again there, can it work? The efficacy, it's usually based on the clinical literature, and that will always be done with the systematic review. Does it work? Effectiveness, and this is the real life situation. And then again, this sometimes will be a systematic review, sometimes not, depending on the question and the available literature that's out there. So as I said, we provide advice to the minister. So how is that evidence from systematic reviews incorporated into that final advice? So unlike guidelines, there's no formal criteria. There isn't an evidence decision-making criteria that is clearly documented. Instead, it's considered informally within those domains. So we have those 9 domains, which is that framework that we're applying, but we don't clearly, it's not clearly documented along the way. However, it is included, and it is informally considered. Where evidence is lacking, the economic evaluation is unlikely to perform. So this is what I was talking about earlier. As we go through the processes, we stop and we consider what to do next. However, the quality of the evidence will influence that advice that's given to the minister, and the wording of that advice will be influenced by that quality of the evidence. I think it's probably clearest to give an example of this. Yep. So give an example of a HTA I worked on a few years ago, and this was around cervical screening. So this was looking at changing from cytology to HPV testing in the screening system. So we did 2 clinical systematic reviews to underpin this HTA. The first systematic review compared liquid-based cytology screening against HPV testing as the primary screening test. So this is essentially comparing current practice as it was at the time, liquid-based cytology screening, to the intervention people wanted to change to, or we were asked about, which was HPV testing as a primary screen. So we found good evidence that HPV testing was superior in its sensitivity to liquid-based cytology. The second systematic review we conducted was looking at the triage options. So if you have a HPV primary test, what should that be followed up with? What should be the second test? And here the evidence was less clear. But one of the things important to note that all of this literature related to unvaccinated women, because as of that time, women who had been vaccinated hadn't reached the age to be screened, and there was no evidence on how cancer would be detected through screening for these women. So we had clear evidence for unvaccinated women, but for vaccinated women, we weren't sure how well the screening test would work. It was plausible to expect them to work the same, however, the evidence wasn't clear. So when we did our cost effectiveness evaluation, for the vaccinated women who were vaccinated against HPV 16 and 18, none of the strategies in the HTA, which considered a maximum screening interval of 5 years, were considered cost effective. So by purely cost effective, none of these strategies were cost effective at that threshold of €45,000 per quality adjusted life year. Of the strategies that were considered, with the lowest incremental cost effectiveness ratio, so that's kind of the best value one, at 58,745 per quality, was primary HPV testing, followed by liquid-based cytology tests at 5 yearly intervals from the age of 25 to 60. So this is for the vaccinated cohort. When we looked at all the strategies, none of them were cost effective at the threshold we normally apply, 45,000, but the most cost effective was 58,000. But if you remember, we have no clear evidence about how screening would work for vaccinated cohort. We would assume that it would work, and it's plausible to assume that it would work in a similar way as it would for unvaccinated women. For the screening test should work the same, but there is that uncertainty. So when we gave the advice, we said, given their lower risk of developing cervical cancer, screening women vaccinating against HPV 5 yearly intervals may not be cost effective. That goes back to what we found. Given their lower risk, it might not be cost effective. However, there is uncertainty about this cohort. Essentially, it's new that time hasn't passed enough when we did this HTA to see how screening would work in that cohort. So given that uncertainty, screening at 5 yearly intervals should continue while giving consideration to increasing this screening interval as evidence emerges to support the long-term effectiveness of screening women vaccinated against HPV. So essentially, our advice was to screen at 5 yearly intervals until evidence is available to suggest it could be longer. Because from a conservative point of view, we want to be sure, and the evidence wasn't clear at that time. There wasn't evidence, and essentially it's just a timing process. So we want to be clear, and that was the evidence that we gave. So you can see here that the lack of evidence from the systematic review and how that feeds into the advice, how it is worded to include that uncertainty. It's not just about the evidence from the cost effectiveness model. Okay, so that was just to give you an idea of how systematic reviews feed into health technology assessments and how they can impact on the advice. But finally, I'm just going to briefly talk about the work we're currently doing for COVID-19. So I think everybody is probably familiar with the National Public Health Emergency Team, which are advising the government in its response to COVID-19. So how are systematic reviews of evidence informing this advice? So as before, with all healthcare decisions, we want the best evidence we can to be included and to be considered when recommendations and advice is being formulated. So how we're working with systematic reviews. So we're working with the expert advisory group, which consists of clinicians from a range of different specialities, and they're considering clinical issues, and then they take these and they bring that advice to the NEFIT. So the EAG, this expert advisory group, are identifying questions that require evidence, and HIQA's HTA Directorate, with support from other directorates within HIQA and support from our academic colleagues in the RCSI, we produce what's called evidence summaries. So the idea here is, even in this really fast-moving situation we find ourselves, evidence is important. And evidence and systematic reviews have a place, even in this time-constrained area, and even when the evidence is changing rapidly. So how are we doing that? So because we have so much little time and because the situation is quite different, we've had to adjust our processes. Now, some of it stays the same and some of it has to change, simply to maximize what we can do with the resources that we have. So here is sort of an overview of what has stayed the same and what has changed. So on one side, I have what's a typical process in a systematic review. On the other side, what we're doing for the evidence summary. So the first bit is the same. That structured clinical question, that scoping with the people who are asking the question, that clear dialogue, so everybody knows what you know, so we understand clearly what they're asking for, and we can formulate that in such a way we can look to the literature. In a normal systematic review, we would publish our protocol. At the moment, we're not quite publishing it, but we are putting it on our website, so it's up there. I can see there it's live, because normally in a protocol you have the time to think about all the methodology before you start, whereas now we think we're getting all the methodology right, but at times some of the aspects have to change. For example, the quality appraisal tools we put in the protocol, we didn't realize some of the evidence required different, so we had to change some of that. So it's a live protocol. We accept that we might not get all of the methodology right up front, but we will adjust and be transparent when we can. In a systematic review, we do a detailed search of published and grey literature sources. For the evidence summaries, we are doing published literature sources. We're doing limited grey literature, but importantly, we're including preprints. Now, this is something we wouldn't normally do in a systematic review because typically they are not, they've not been through the peer review process. But given the situation we're in with COVID-19, and we want as much evidence as we can available to those making decisions, we are including preprints, but that does have to be, you know, a large caveat around those. Systematic review, you do double screening, double data extraction, double quality appraisal. It's all be formed independently by at least 2 individuals. At the moment, to get these things turned around more quickly, it is single screening, single data extraction, and single quality appraisal, although we are doing some checks and some ways performing a duplicate where we can. With the systematic review, we do quantitative narrative summaries. At the moment, it's narrative summaries only. We're not doing any meta-analysis. That grade summary of findings table, we are not producing that grade summary of findings tables at the moment. For systematic review, we would have a full detailed report. At the moment, we're producing summary reports. So we're excluding certain elements just to make these shorter and easier to produce and easier to understand by those who are trying to read them. So we exclude elements. For example, we exclude the Prisma flowchart, we exclude the quality appraisal tables. The quality appraisal is done, but we don't have the table in there, but we do have the data extraction in there. And instead of a grade summary of findings, we have key points where we list out the key findings, and we do always in those key points, or in the latter ones anyway, have this is what the quality is saying. Systematic review is normally about 4 to 6 months for us in HIQA to produce. The evidence summaries are 7 to 10 days. So these are fast turnaround, as fast as we can make them, so that they have the evidence to hand to make the decisions. In a systematic review, we don't routinely update them, whereas in an evidence summary, at the moment, some of these questions, the evidence is changing so fast that we update the reviews as required. So we update, I think there was one of the first reviews we did around infectivity, we updated 4 times. So week after week for 4 weeks until the expert advisory group felt they had enough information and the literature was beginning to become clear. So that's how we're producing evidence summaries to support those making the decisions. And again, as with the HTA and as within the clinical guidelines, the evidence is only part of the decision-making process, but it is an important part and it feeds into the wider decisions that are being made. So to date, we've been asked to produce 14 evidence summaries, and 6 of these are on our website, and the protocol outlining our methodology is also there, which gets updated as new questions arise, and if we find things that we can improve on our process, we update our protocol as necessary. Okay, so that's all I wanted to go through. I've got some extra reading resources there on the slides, but I think that's the end of the presentation. If there are questions.
That's great, Shelley. Thank you so much. That was so interesting and so clear as well. It's just great to see exactly how evidence informed decision making and particularly fits into those frameworks. And as you said, it's, you know, it's a part of the puzzle, and it's a part of the jigsaw piece, but a very important part of that. I'll just ask a few questions while I'm waiting for people to ask some questions, either in the chat box or in the Q&A. And we have thanks from Anna Hobbins for an excellent webinar, and from Victoria Doyon as well for very insightful and informative as well. So kind of go back towards the start as well, and a question we often have is with regarding the critical appraisal tools, are there any other ones that you would recommend other than Agree that you use or you have experience with?
Oh, well, we typically follow the Corcoran processes. So we will use the Corcoran risk of bias for our randomized control trials. We would use a Robbins I for observational studies. For cost effectiveness literature, we would use, we tend to use a mix there. We tend to use a mix of the ISPOR tool as well as the CHEERS, which is more geared towards systematic reviews. So I mentioned the Agree tool there because I think sometimes people think of quality tools when they're thinking of literature, published literature, and they forget about them when they're thinking about that more grey literature sources. But you need to use the right tool for the right study design. So if you're reviewing a systematic review, you'd use AmStar. If you're doing a diagnostic study, usually the QDOS. So it really, like, you have to pick your tool for the type of study you're looking at, and it's very important that you get that right. I would probably point people in the direction of Corcoran for what's best practice, but it is important to make sure you have the right tool for the right study design. And to remember that grey literature also needs to be quality appraised.
Great. I have a question here. I think you kind of answered it. It was just, in your experience, what is the role of public and patient involvement in developing clinical guidelines, and where can patients be included? But you did say part of the groups is the patient voice.
Yes, exactly. So for the clinical guidelines and for health technology assessments, patient representatives will always be part of those included stakeholders. You know, they are key stakeholders. For health technology assessment, we also do public consultations. So as well as having that patient representative on the expert advisory group, we will also send the HTA out for public consultation to allow general members of the public to input into it. And some of the guideline development groups, when they're doing their consultation on their draft guideline, will send it out and allow the public to input as well. So they are a key part of that guideline development group. They are a key part of that expert advisory group in HIQA. But there's also that the consultation stage and the opportunity for wider public input there as well. I mean, it's really important to get that input, and it's really important to get that input early. So for the guideline development group, when you're formulating the clinical questions, it's really important to get their input on what are the important outcomes for the patient's point of view, and sometimes what are the important questions from the patient's point of view. So they have a stake across the development.
Absolutely. I have a question here from John McQuaid. How and who decides which clinical guidelines are updated?
So this is part of the NCEC prioritization process. So for any new guideline, it has to be submitted as a priority. You know, there's a process that they have to submit their guideline for prioritization by the NCEC, and then that will be appraised by a prioritization team and go to the NCEC committee, so National Clinical Effectiveness Committee. And this again has, this is a wide committee of stakeholders who will make a decision on whether that should be prioritized or not. They have a clear process and a clear criteria that they consider when they're considering prioritization. So that's for any new guideline. For any updates, again, it is if they're already within the system in the NCC, then it will be a discussion within about whether they need to be updated or not, and the same processes will be followed.
I have a question, a comment here from Niamh McGrath. She says, thanks very much, Shelley. That was really informative, interesting. I'm wondering how you use qualitative evidence synthesis and how much of a role these play in your work.
Oh, that's an interesting one, because this is something we've only recently started to do about the qualitative work. So we've done 2 qualitative systematic reviews to date. One for the National Early Warning Score. So one of the qualitative reviews were the barriers and facilitators for, essentially, in an early warning score, you raise the question, you trigger it up through, so a nurse would trigger it onto the clinician. So we did a qualitative review around the barriers and facilitators of this. So why aren't they triggering it when they should? Are there barriers and facilitators on this? So a qualitative review to understand some of the issues there and some of the things that might need to be done from an implementation point of view in the guideline to ensure that this is happening. The other qualitative review we've done to date is to support the care of the dying adult guideline. And this was around spirituality. So this was looking at the patient's perspective of their spiritual needs at the end of life. So again, this was really interesting review across, what do patients actually want? So at that end of life stage. So this information is then fed back to the guideline development group, and we found some interesting themes about connection with family and friends, a connection with the, it's not quite religious, but that sort of existential point of view, and then how, the guideline group can consider how that might be facilitated and how we can best meet those patients' needs. So there are 2 examples we've done to date about how qualitative evidence is being inputted into the guidelines, but I do feel this is something that's, it's something new, and we're beginning to do more of it, which is great to see those wider issues being included in guidelines.
Yeah, absolutely. And we have a qualitative evidence synthesis stream in ESI that's curated by Polly Mescal in UL and Linda Beastie in NUI Galway, and some excellent work that just recently come out with a QES on infection prevention and control led by Catherine Houghton, and it's just, you just get such a rich data set from it. It's great. And Louise Farr here. Hi Louise, she's a question said, thanks Shelley, that was really informative and helpful, especially for the description of the rapid evidence summaries. I agree there, Louise. Do you generally have an information specialist as part of the team?
We don't actually have at the moment for the evidence summaries, yes we do. But as part of our team, we don't have an information specialist. However, we have a lot of the team who are familiar with this, and we have information specialists who support us. So at the moment, as part of the evidence summaries, given the short turnaround, we are getting dedicated support through our colleagues in the RTSI as an information specialist. But no, typically we don't have a dedicated information specialist, running those library searches for us. But we do have people we call upon to review what we do.
That's great. I'm conscious of time now, so I just really want to thank you, Shelley, for the time you've taken for this, and that was just such a clear presentation and certainly answered an awful lot of questions that I had in my head and helps me contextualize how evidence is used. And I think it's just so important, and thanks for all the work you're doing on a national level as well. And I will have the recording of this up on the website over the next couple of days that I'll share with everybody. Thanks everybody for taking time to join us today. And as I said, please do follow us and fill out the feedback form so we can continue to update you with other evidence synthesis topics. So thank you again, everybody, and take care. I'm going to talk to you soon. Thanks, Shelley.
Great. Thank you very much. My pleasure.
Bye.